showing any variations in their facial expression, then we say that the affect is blunt. The affect can be blunted or restricted. Now, when you interact with the patient may appear blunted. There is a reduction in the range of affect. They don't show any affect. Flat and the blunted affect are almost the same, except that the blunt is not as severe as the flat affect. Lipo affect refers to rapid changes in the affect. So 1 minute, the patient is laughing loudly. The second minute, the patient is showing sadness or they are crying, and then they be agitated and so on. So the affect can be labile, meaning it keeps on changing and the change occurs very rapidly. Now, the affect can be full or wide range, meaning that they show all the appropriate presentations. When they are discussing a sad event, they can express that visually. When they're discussing a very nice event, they'll be probably showing happiness and so on. So there's full range of affect or there is none. So record all that. Now, mood and affect sometimes are synonymous, but then there's some slight difference in that. Affect is what the patient expresses, whereas mood is what they experience internally. So mood is an internal experience. The patient is the one who feels it. You might not be able to tell until you probe, right? They may tell you they are feeling sad. They may tell you they are anxious. They may tell you they are angry. They may tell you they are euphoric, feeling happy. Dysphoria, that is variations in mood. They may be what we call euthymia, meaning that their emotions are normal. They are feeling good. They are feeling anxious. That's another presentation of the mood. So moods is what the patient internally experiences, and most of the times they'll be able to tell you when you probe. Now, thought process. Thought is use of language, and that's where we can access the thoughts. And we can only infer what's happening from the speech. So the patient talks, and out of what they speak, we can be able to say what their thoughts are like. What we're interested in here is the tone, the fluency of the speech, coherence. Is a patient able to articulate their thoughts? So we look for the tone, the coherence, and the quantity of the speech. Are they able to produce enough speech? Is the speech retarded, right? They are, like I said, thoughts and speech, they go together. Can you pull this slide up? Okay, good. What are the common thought disorders, and how do we recognize them? Now, remember what I've said, the speech and thought, they go together. And you can be able to, number one, note the speed at which the person is talking. Is the speech rapid? We say it is there's pressure of speech. Sometimes there is poverty of speech. In other words, they produce very minimal responses. And a good example is when you ask them questions, they just say yes or no, monosyllabic speech. So you may not be able to determine what it is that they are thinking because they're hardly talking. Let's move on. Okay, good. Sometimes there are a number of abnormalities that occur in the thought process. For example, there's blocking. And in blocking, we say there's sudden cessation of speech, often in the middle of a statement. So the patient starts talking, but somewhere along the line, they stop and they tell you that they're not able to continue, or you notice that they're not able to continue telling you what they were initially intending to tell you. We call that thought block. There might be what we call flight of ideas, and here there's accelerated thoughts. The thoughts are jumping from one idea to another one. So, and they speak very rapidly. The flight of ideas is a very common presentation in a condition we call mania, and we'll be demonstrating this to you in the word teaching. We may have what we call loosening of association, and here is when the thoughts are so illogical, they are not related to each other. They keep on shifting from one idea to the other one. So the patient may start telling you about their school. Somewhere along the line, they stop talking about their school and they talk about their family or something else which is so unrelated to the idea that they started expressing. So we refer to this as losing of associations. Their thoughts are not associated, and you cannot make any good conclusion out of what they've told you. So they keep on shifting between unrelated topics. There's what we call tangentiality, and this is a description of how the thoughts wander from the original point. So they may start telling you about an idea, but along the way, they digress from the original point. That is, they take a different tangent. The other abnormality is what we refer to as circumstantiality, and this is unnecessary digression. However, they finally will make a conclusion that is relevant. They detour quite a lot. Circumstantiality is commonly seen in most of the schizophrenic patients, but they keep on telling you about an idea. They digress into another line of thinking. For instance, you may ask them, how did you get to the hospital? And they may start telling you how they woke up in the morning and prepared to come to the hospital. But along that line of thought, they may stop and move on to something else. They may start telling you about their secondary school education. And after that, they may come back to the original line of thought, answering your question on how they go to the hospital. Echolalia is a phenomenon where the patient echoes words or phrases, and this is seen in patients who keep on repeating what they've heard. For instance, if you are interviewing the patient, you may ask them, what is your name? Rather than tell you they're called Smith, they will ask the same question, what is your name? So echo is echoing what they've heard. Neologisms is a common thought problem where the patient invents new words. In other words, they create their own words that do not exist in any language that is known. So they fabricate words. Now, neologisms have been thought to be some forms of many letters, first two letters of a word. For instance, if you look at J, they may start with CL, then move to the next word, SP, then they move to the third word, which is based. So combination of CL, SP, BA, that is a neologism. right? And to the patient, they can keep on repeating the same neologism, which doesn't make any sense to other people. Clanging refers to speak based on sound. So there is rhyming and punning, and the observers may not be able to understand whatever the patient is communicating. Perspiration is a disturbance where patients will keep on repeating phrases or words in the flow of their speech. So they may be answering the question, what is your name? And they will say, Peter. What is your father's name? Peter. What is your mother's name? Peter. They keep on repeating the same phrase, and it is irrelevant to the question that is put to them. Perspiration. Ideas of reference is another thought disturbance where the patient feels that they're being marked, they're being targeted, and they interpret whatever is happening in their environment to have some direct relevance to them, such as that the television is talking specifically to them. So they may be sitting in front of a television and they may be conversing with the presenter because they believe whatever the presenter is saying something about them. So there is that a disturbance. Now the thought content, let's move the slide a little bit high. Yes, thought content. The patient may suffer from hallucinations, delusions, and other perceptual disturbances which they may hold in their thoughts. So the common thought disturbance, number one, let's remove that word definition there. Common thoughts disturbances, or the content of what their thoughts may have or contain. For instance, thoughts may be expressed through hallucinations. And the hallucinations is a false sensory perception, which may be auditory, visual, tactile, gustatory, or olfactory. So the patient may tell you that they are hearing voices. We refer to those as auditory hallucinations. They may tell you they are seeing. We'll refer to that as visual hallucinations. They may complain of being touched on their skins, tactile hallucinations. They may complain that they are tasting something, although they have not put anything in their mouth, but they are still tasting. We refer to that as gustatory hallucinations. And sometimes they may hear things that are not there, olfactory hallucinations. The content of what they tell you, thought content, there are a number of abnormalities that can be found. Number one are delusions. And delusions are fixed false beliefs which are firmly held by the patient in spite of contradictory evidence. Now, the patient may hold a belief that they possess supernatural powers, that they can be able to perform miracles and so on. Some of them may claim, for instance, that I am Prophet so and so. So they have this false belief, which is so firmly held. As much as you try to tell the patient that this is wrong, that what you believe is not right, and there's no evidence, they keep on telling you, no, you must be wrong. I am Allah, I'm Muhammad, I'm Jesus, I'm the king, and so on. But then there's no evidence. Delusions can take very many forms. Persecuted delusions, for instance. This is a belief where the patient believes that they are being spied on and they will be probably harmed. So they feel persecuted. So that's one example of what a delusion of delusions, persecuted delusions. Another example is erotomanic delusions. These are false beliefs that a person, usually of higher status, is in love with them. You probably, patient will come and tell you they're in love with the king, the queen, and so on. They may even act on those delusions, like visiting prominent people's premises. They believe that they are in love with them, and it is their right to go there. Grandiose delusions, I've given an example earlier on, where the patients have inflated sense of self-worth. They believe that they're very important. They believe that they have special powers. They can perform wonderful, miracles. They can achieve something that is not achievable by majority of the people, and so on. So grandiose delusions is where there is a false sense or belief that they are very important. Their self is very, very inflated. They have supernatural powers. Grandiose delusions are very common in people suffering from bipolar disorders, the mania type. We'll be demonstrating this in the patients during ward teachings. You also have to assess their cognitive functions. That is the level of consciousness, their orientation. Do they know who they are? Do they know where they are? And the time of the day. Attention and concentration, again, there are ways in which you can be able to determine this. For example, you can give the patient 5 digits and you can ask them to repeat them forwards and backwards. You can also probably give them a letter, for example, the letter word, and you'll ask the patient to spell the word forwards and backwards. This will be able to give you an idea of how well they are able to concentrate, how attentive they are. You also determine their short-term memory and long-term memory. The short-term memory, what you want to find out is the ability to recall 3 objects after 5 minutes. So you can give them some objects like chair, cat, pen, and 5 minutes later, you ask them to recall those 3 words. The long-term memory, you may probably ask them about events in their lives when they occurred and collaborate whether what they remember is the truth. In the examination of the cognitive functions, you also want to find out the fund of knowledge. How much knowledge do they have? Can they recall, for instance, the presidents in their country and when they ruled, which cities they are, in their country, some historical dates or events that have taken place? That will give you an idea about their fund of knowledge. Maybe you can also assess their educational levels and so on. Calculations. Again, we had talked about the concentration and attention. Again, by giving them calculations like a subtraction of series 7 or simple mathematical problems, you can determine their ability to do calculations, but also be able to determine whether they are very attentive or they're able to concentrate. Abstraction is some form of examination where you want to find out whether these people can be able to interpret proverbs, whether they can make similarities between objects. I can't see the slides anymore. Can?
Doc, can you see my screen?
I can't see your screen, eh?
You can't see it?
Yeah,
Can
no,
you see it now?
No, it's not up yet.
Oh.
It has come, but very tiny.
Okay, let me just fix it.
Yeah, make it a bit larger. We've already seen, talked about all this. Let's go further down up to cognitive functions.
Okay.
I can see this the screen, but yeah, that's where we are.
Okay.
Oh, no, go up a bit.
Inside.
Go to the previous screen.
Yeah, we were abstraction.
That one, eh?
Inside.
Yeah. We're talking about abstraction, eh?
Yeah.
And the way you can test abstraction is give the patient a proverb, eh? And find out whether they're able to interpret that proverb, eh? Yes. So the easiest way of assessing abstraction is by giving proverbs and see whether they're able to interpret those proverbs well. Haraka haraka haina baraka. Find out whether they understand what that means. Insight is the ability of the patient to display an understanding of his current problems and the ability to understand the implications of these problems. So you want to find out whether the patient is aware that they have a problem, they have a disorder, they have some problems that are bothering them. We say that the patient may have full insight, meaning that they're able to come and tell you, doctor, I have this problem. I know it's a problem. And I know through medication, if you treat me, I'll get better. So that is full insight. They're fully aware of their current condition. Insight may be partial, where they may know that they are unwell, but they have no idea that they should be treated, or they assign different meanings to whatever is happening to them. So the insight might be full insight or partial insight. You also go further and find out whether the patient has got illusions, and illusions is a misinterpretation of the reality. So there's a stimuli. You show them a phone, but then they may call it something else. There is some difference between illusions and hallucinations. In illusions, there is misinterpretation of a stimuli. In hallucinations, there is no stimuli, and yet the patient insists. There is what we call derealization. Derealization is feelings of unrealness involving the environment. So the patient may be standing at a point, they check the surrounding, and the surrounding, although it's a familiar surrounding, it appears like it is totally changed. So derealization has to do with the environment, the outer environment. Depersonalization is where the patient feels that their body, their real self has changed. They see themselves outside their bodies, and it's like they're observing their own self from far. So depersonalization is a feeling of unrealness. Suicidal and homicidal ideations, this is where the patient will entertain ideas of death or causing death to another member of the family. And this is a very important area that should always be explored, because by probing, because hardly will the patient come out and volunteer this kind of information. Judgment, and this refers to the ability to make sound decisions regarding everyday activities. And the only way you can be able to determine if the judgment is good is by assessing the patient during the history. During the history, as you take different parts of the history, you're able to determine whether this person is giving you history that is relevant, and they're able to associate all the ideas to make coherent, complete info. The other way you'd probably be able to tell whether the judgment is good is if they have the ability to make sound decisions regarding themselves, the environment in which they are in, and avoid being hypothetical when you are assessing judgment. Give them real life situations. Okay. Let's see if there's any other side. Good. Once you have taken the history, there's what we call formulation or case formulation. In medicine, we refer it to the summary. In case formulation, the process of case formulation involves working towards a psychological explanation of the patient's problems that has treatment, implications. Now, we'll be teaching you more about case formulation. Let me state here that it has some core elements. And what you do is you start by describing the presenting issues, right? What has brought the patient to the hospital? So give a statement of that. Then you go further and give us, or try to find out what predisposed this particular episode. That is factors that are more recent, that is acted on the patient so that the patient presents the way he is actually presented. Factors like genetics predispose people quite a lot to developing certain kind of mental illness or any other diseases. So predisposing factors more recent, that is more recent factors that acted so that the patient has now come presenting the way they are presenting. Precipitating factors, they may not be very immediate, but again, what has precipitated this occurrence? What has perpetuated this occurrence? Now, this may be probably they have not been very compliant to their medication, or probably they are using mind-altering substances, alcohol, cannabis, and many other substances that will alter their mind. And finally, you want to find out what are the protective factors, and this sometimes has to do with their resources. What is it that has kept them well? Maybe they've got a very stable family, the medicines are available, and they're able to access health facilities very quickly. Now, the final slide needs a little bit of alteration. We are now using what we refer to as DSM-5, not DSM. So the diagnosis is a DSM-5, not anymore. And once you make that diagnosis, we'll be telling you more about the DSM-5. You now have to plan how the treatment will be done. There are 3 modes of treatment. There is the pharmacological treatment, there are the social treatments, and there are the psychological treatments. So in the pharmacological treatment, you determine what are the best medicines to give. They could be antidepressants, antipsychotic medication, anticonvulsant medication, depending on the diagnosis. And then you determine whether this patient requires hospitalization or not, depending on the severity of the illness. You may decide whether to put the patient in hospital or you treat them from outside. I talked about the psychological treatments, what we call the psychotherapies, and many other interventions. Of course, once you have an impression of the diagnosis that you have, you need to do investigations. And investigations will take two types. There are the medical investigations if they're indicated, and also the psychological investigations and social investigations. Social investigations involve the collaborative history. You want to get more information about this patient. The lab investigations may be indicated if you suspect that there could be some illness or you want to rule out something. For instance, you may do drug screens if you suspect they are abusing substances. So the laboratory tests are done to rule out any physical condition. Like I mentioned a bit earlier, conditions like endocrine disorders need to be ruled out in presence of certain psychiatric illnesses. Good. So those are the investigations that you could do, and I'm sure that you know much about them. So like I said, laboratory studies will be based quite a lot on the clinical findings. That's what determines whether you're going to perform biological investigations. Good, which are all listed there: blood chemistry, thyroid function test, and most others. Good. I think we should be seeing the last slide now. They are very, the slides are very tiny. Make them larger. So that is it. Based on your clinical findings, then you determine which other studies, laboratory studies that you're going to do. Right. Let's see if there is any more slides left. Can move on. I think that was the last one. Yeah. Yes. Are there
Yes,
any
Doc,
questions?
there are no more slides.
Yeah. Are there any questions from the group? I know you are very many of you. You said you are how many? 300?
Yeah,
Huh?
around 400.
Around 400, yeah? So there might be no questions, but if there are any, I can entertain one or two. Yes? Emanuela, Mwinga.
Yes, they can check the chat box. Harshil can check the chat box.
Oh, they're in the chat box, eh? Let me
My
see.
question is,
Let me check the chat box. Let me see here. Yes, Gitari. Okay, let me check. Let me check no, this chat box. No, haifunguki. Oh yeah, hakuna kwa chat box. Okay. Okay, good. Whoever is asking a question can talk now.
my question is,
Yes.
for the patients who have not accepted the condition, how do you handle them, or how do you deal with them?
Okay, good. Now remember at the beginning I did say this, you listen to the patient and then you also do collaborative history, and I told you that there are patients who will not agree to come to the hospital. We say they are involuntarily admitted or brought to the hospital. The relatives are the one who make that decision, and when they come to you, they may not even talk to you, but you do general assessment and behavior. You observe them, their general appearance and behavior. You may find that they are probably walking naked. They have got abnormal body movements. right? So you observe that. And then from the relatives, they'll give you the history. They'll tell you that our brother has been abusing cannabis, our brother has been drinking so much, and for the last 1 month or so, he's been living in the streets, right? From that collaborative history, from the observation that you see, then you'll be able to come up with a probable diagnosis, right? So
Yes.
patients who are not cooperative, you use the significant others, that is the relatives, or anybody else with info about this patient. Yes.
And in treatment now, if they are not cooperative, they won't be taking medications. So
Yeah, right. Now, that is very good. You determine whether they need hospitalization, or you're going to treat them as outpatient. While they're in the wards, the nurses will ensure that the patient takes treatment. They may fail to take the oral medication. We have medicines that are in form of injectables, which are depot injectables, which you give once every 4 weeks. And this way, you'll be very, very sure that your patient is now under treatment, even if they're not cooperating. Right? We'll be teaching you, there will be lectures on pharmacology, psychopharmacology, and all the medications that we use in treatment of psychiatric disorders will be discussed. There are the antipsychotic medication, there are antidepressant medications, there are anticonvulsant medications, anxiolytic medications. So lectures in psychopharmacology will cover all that, yeah? Good. I'm only now sort of introducing to the subject of psychiatry. Good.
thank you.
Any other observation? If there are no other concerns,
I think we're okay, Doc.
yeah,
We have another class right now.
yeah, you should be joining another class.
Yes.
Otherwise,
It's already
thank you, Khan, for being very useful. I'll
no
count
problem.
on you in future.
Thank you, Doc.
Thank you.
Okay. Good day. Let's end the class.
speed at which they may start telling you of doing this, for example, is the ability of the patient, is if they have the ability